we don't have slides for you guys. We have a test Friday, like y'all's is Thursday, ours is Friday. So like we're grinding too for this stuff.
Yeah.
So yeah, so we're just gonna kind of do like we did last time and go through it, and just kind of point stuff out. But we did not have time to prep for this. We just want to try to help where we can. But term 4 has officially like really slapped us in the face. We get like 20 new drugs a day, and it's just yeah. So we're gonna do our best.
Look forward to it.
Yeah. Anyway. All right. So let's see. Let me share my screen.
And we had our first SOAP assessment, so we feel like actual medical students now. Which is fun.
What happened here? Oh, here we go. Okay. So few things I wanted to point out. This is on my drive, but I believe it's in one of the clinical lectures. I think I just took it out of one of the clinical lectures, but if for some reason this looks new to you, find it in my drive. This is the most elegant way of trying to learn these ganglia. I know it's still kind of a lot, but all the other pictures I had found doing it were much worse than this. So you need to know, what travels through what ganglia. Remember that the sympathetics and parasympathetics piggyback on it. Not only that, some of them actually synapse in the ganglia, right? That defines what a ganglia is. It's a cell body outside of the CNS. So you see a lot of these parasympathetic fibers, these red ones, they synapse in the autonomic ganglia. Okay, so you're going to want to know, what travels through it, what synapses, which are these parasympathetic ones, and where the end targets are. So unfortunately, it's kind of one of those things you just have to memorize, but make sure you know these and certainly know what the end targets are, because they can ask you if there's some sort of lesion somewhere, what is going to be affected specifically in the ganglia. What else? So for Dr. Haig's lectures, I know his lectures don't have a lot of explanations. So the Grace questions are going to be your best bet for those. Try to get through those. That'll help with that. One other thing before we look at the lectures. So this is also on my drive. What I went through Dr. Burkhart's cases, and I just pulled out a few of the slides that were explanatory for some of the different symptoms. So like they could ask you about Weber syndrome. The point is, I didn't want to go back through the cases a bunch of times. I just wanted to pull out the important slides so I could look at them. So like for Weber syndrome, you're going to have a infarction here that directly affects cranial nerve 3. So this kind of just shows you where it is in case there's a question about it. This was one of those things that Shan Stokes breathing. But you do, on this note, you do need to know the different types of breathing, where it breaks down in the brain. But this was one of the ones from his stuff. We'll get to that. And then what is this? This is Wallenberg syndrome. So it's one of those things where you kind of just need to memorize the symptoms and where the location is on the brainstem, and it'll kind of tell you. But if you look at these enough, they should stand out to you in the context of the question. Yeah, and this is just an explanation of the previous slide. And then this is another one. This is one I do remember. I was like, this definitely won't be on the exam, and it was. So it's like one of those really weird ones, whatever it's called, foveal syndrome. But yeah, so you just want to have a correlation. I think the Wallenberg and the foveal syndrome are a good explanation of how you can get one side of the body being affected, where you can get the other side of the head. So depending on the level, remember those cortical bulbar fibers cross at a different level, a little bit higher up than the wood at the ones that go to the body at the base of the brainstem. So I think that's why they like to test those, right? Because it's a different track. Anyway, you could find those in the in my drive, but I would go ahead and at least do those once, those clinical cases for Dr. Burkhart, just to make sure you can work through those. I mean, they're pretty user-friendly. Whoever made those PowerPoints, it's user-friendly. So that, and then also the cases that, I don't know his name, that y'all did recently. Yeah, y'all know what I'm talking about. The clinical cases that y'all had. Let's see, these cases. Yeah, I'm gonna butcher his name, him. These cases. So these are really important too. So we'll get to those in a little bit. So the plan is, again, y'all have to please bear with us because a lot of it, we haven't looked at this in a while. So a lot of this is going to be like a, oh yeah, we remember this now, like type thing. So we'll try to jog our own memory. So we tell y'all what was on the exam. Okay, so triangles of the neck. You know, I didn't really like this too much. It was a little convoluted, but some of the really important things are differentiating a thyroglossal duct cyst from a cervical sinus. Remember, by defining a thyroglossal duct cyst, it's midline and it moves with swallowing, okay? That's what they'll tell you in the stem. And that's just because it's attached to the muscles here or the fascia here, so it'll move. And then the cervical, I think this is a goiter. This may be a cervical sinus, I'm not exactly sure. But the cervical sinus is on the side and it will not move with swallowing. So they could ask you a third or fourth order question that talks about the embryological development of this, but make sure you know the difference. So thyroglossal duct cyst, midline moves with swallowing, and the cervical sinus is off to the side and does not. I would definitely be, I think the question we actually had on the exam was an MRI of it. And it was like off to the side, or it was in midline, you know, and it's like, you know, if you know that, then you should be good. Okay. And again, my notes are posted. I did what I did for NB1. I posted all of this, all of my annotated notes and my condensed notes for the exam. So everything is posted there. So y'all have all this. Now, this is an important thing here. I remember this, knowing the different layers and where they lay in this axial cut. This carotid sheath is off to the side, and you need to know what runs in there. But I think the question they specifically asked was about this bucopharyngeal fascia, how it runs directly posterior to the esophagus. So there's the trachea, there's the esophagus, and the bucopharyngeal fascia is there. Another question that reminds me, they asked, I don't even know if I ever figured out the answer to this. I think this is one I had a guess on the exam. They asked if you do a tracheotomy or the emergency one. What's the emergency one called? The laryngo? Anybody know off the top of their head? Laryngotomy, something like that. Anyway, know what layers you go through when you do the emergency one and the one where you do it, where you can do it in the ER. So they're going to tell you in the question, if they tell you in the question that the person that's choking gets to the ER, assume they do the one that's higher up. The reason, if it's an emergency situation, and this is like, don't ever do this, but like this is in movies, right? Where you see somebody choking and somebody grabs like the hollow part of a pin and like jabs it in their neck and like saves their life. That's a good way to get sued, actually, even though you look like a hero. But yeah, so the reason, so it's easy access if it's an emergency situation because it's lower down. I can't tell you off the top of my head what layers you go through. I think it's the bucopharyngeal, that's what jogged my memory, but it's a little lower down. Now, there are a lot of nerves that travel there. That's why if it's an if the patient makes it to the ER, they actually go a little bit higher up because they're able to make a midline incision to do that. But know the different layers that you go through for each. So there's a little homework for you. And somebody could post it in the chat if they came across that. Okay. And then obviously you know that the sternocleidomastoids control opposite way. So if you're looking to the right, it's your left SCM that's working. It's counterintuitive, right? You would think you would contract same side, but it contracts the opposite side. So if you have an injury to your right SCM, you're going to have difficulty turning your head to the left. Okay, so that's contralateral to the action of movement. Let's see, a lot of this is just going to be like going through Gray's questions. If I come across the one, they had one of these on our lab exam. Do you remember that, Lindsey? The lab exam, they had like the midline and it had like the ansa cervicalis. Yeah, so I know y'all lab exam is a little bit far off, but make sure you look through those lab quizzes that they give y'all, because those were very representative of what we saw. Like, take the pictures and not just what they asked you, but if you could identify everything on the picture, you should be good to go, because we had a neck question that was similar to this, right? So it had like the ansa cervicalis and you could kind of see it transected. Okay. So if you haven't looked at my notes before, the red means you need to know it, or I felt like I needed to know it. Green is kind of a little bit less important and yellow is less important. So that's if you're kind of wondering what I felt was important going into the exam. A lot of the red stuff is like buzzwords and stuff like that. So, and I didn't go back after the exam and like do this according to the test. This is kind of like, as I was doing it, I was like, I want to know this. So it's not black and white. It's just kind of what I felt was important. Let's see. And Lindsey, feel free to chime in if you see anything super important. Okay, so here's one thing. And then if you look at my annotated notes, my condensed notes that I make right before the exam, I went through and wrote out what nerve does what muscles in the beginning part, just because these are easy test questions to get confused, right? So some of these are coming from different nerves. So what I did was I took, you know, a cranial nerve B3 mandibular, and I said anterior belly of the digastric, mylohyoid goes with it. So I try to memorize it that way, because you don't want to miss a silly one, easy question. These are just memorization. But as it stands in the neck, you can see that a lot of stuff comes from different nerves. So that's something you definitely want to be sure to know.
I do remember one of the suprahyoid muscles, like a really random one coming up on the exam, and you had to know its relationship to the others to get it. I know that doesn't tell you anything, but that to say, don't skip over this stuff. Know the innervation, know the relationship of the muscles to each other. So when I drew it out, so this labeling actually isn't visually in order. I redid it and I put it in order of where they are with respect to the neighboring muscles. And so just orient yourself like that and know you may get a question where you have to understand that.
Yeah, so unfortunately, this is one of those things, like if you were on the island and you could see it in 3 dimensions, it would be much easier, but you kind of have to lay this out and see what's deeper than what. But larynx and pharynx, if I had to pick one concept that was just like, I didn't really enjoy it, that was probably it, the part of the neck. I don't know, maybe it was just the way it was taught, but again, do the Gray's questions, that'll help with those. I don't know if this really, I mean, this is good to know. I don't know if it really came up. So just a little bit differentially, the carotid sinus has baroreceptors that are going to work with cranial nerve 9, baro meaning pressure, carotid body's chemoreceptors. So it is going to relate to your oxygen and pH. Up in the brain, the receptors also deal with carbon dioxide, but here, it's just oxygen levels and your pH.
You're going to get into these a lot more in NB3 as well, but know which of the cranial nerves, that was huge, and what they responded to.
Yeah. So again, like, and when I do these, like if I was, doing the notes, like the reason I would make these red is just because if I looked at this slide and I was like, what is a test question they could ask about this? I was like, well, look at this. This one's 9 and 10, and this one's just 9. So those little differences are like things I try to key in on. So that's why I try to do it like that. Right. So aren't these the ones that flip when it comes to the pharyngeal? I think that's the one. I have that one coming up. The pharyngeal arches but we'll look at that in a second. But yeah, let's see. Recurrent laryngeal, of course, you definitely want to know that. Remember, If you have any sort of aneurysm or problem with the arch of the aorta, the left recurrent laryngeal will get compressed. The patient will present with hoarseness, right? You could bet that'll be on the exam. They like that one. We even talked about that recently in cardio. Let's see, here's that picture again. So kind of know where the layers are in relation to the organs and the different sections. This was so confusing. I don't even know. I don't know.
Yeah,
I don't know.
This is the most confusing lymph drainage like we've had thus far. And I think we had 1 or 2 questions over this. The biggest thing they like is the, because there's a difference of like the tip of, it's like the tip of the tongue.
Oh yeah.
The tip of the tongue is a big thing because it's different from the rest of the tongue or the rest of the area.
Yeah, it's like, there's an omohyoid and it's jugulodigastric. Sorry, I didn't have the chat up. Let me just see. So we'll get into the thyroid, the derivation of it or the embryology of it in a second. So I have it up now.
Yeah, submental.
Yeah, so there's the submental that does this part. I think I have it in my consolidated notes. Like there's a part that drains the tip of submental's at the tip. Isn't it like jugulo or omohyoid or something? I don't know. Somebody could look that up. Anyway, there's different drainage from the tip of the tongue and the rest of the tongue. If I would know anything from this from the lymph drainage, we'll know what drains into what. Like stuff from the side of the face or the cheek are going to drain into these nodes down here below the chin and stuff like that. But it was, I don't know. It was just, I don't know. This slide just confuses me, to be honest. Yeah. Oh, here it is. Jugulodigastric is tonsillar, and then jugulo-omohyoid goes to the tongue. Yeah, so that's a good general lymph thing to know. They could ask that. But as for this, it gets really convoluted. Just remember the face kind of drains into the part of the mandible and then down along the jug.
Okay, how heavy is the development stuff? Okay, so this is my whiteboarding for the development. Let's go through here and pick out what I remember being a big for this exam. Okay, so these 3 terms are kind of, you can group them together being related. I think anencephaly, holoprosencephaly was a big one. I think that was more NB1, but make sure you still understand it and can identify it from a patient case. Microencephaly, I don't remember that being a huge one in this one. The sutures, that's NB2, yes, the suture closures. You need to understand that. And so the different suture closures, if you have a failure of closure, it's going to be down here. Okay, so early closure of different sutures, you need to understand what happens if, based on a patient case. So I think they talked about failure of closure of one of the sutures, and we might have had to identify what like the patient would look like or something, or maybe it said there was like a long narrow skull and you had to know it was early closure of the sagittal super. So chunk all of these 4 together, or however many they are, and make sure that you are able to differentiate, because that was a thing on the exam. I do not remember the bifidum ones being a huge things. Oof. The cleft lip palate stuff, you will have about 3 to 4 on the exam. Make sure that you understand the difference between the 2. I believe you guys have a handful of IMCQs that go over this, or Sakai questions that go over this. Please spend some time on this. These are easy points if you can get the terminology down, but you will have a handful of questions on these. So you also need to understand if they do unilateral versus bilateral, please understand that. And some of these terms are very close with each other. So for example, this is failure of the maxilla to max bar, I don't remember what I used that for, to fuse with the lateral nasal prominence versus like the median cleft upper lip failure fusion at the 2 medial nasal prominences. So you'll see here, I underlined my key terms, my key phrases. Please, please, please remember those. That will save you 4 to 5 points on the exam. First arch syndrome, I do remember this being a thing. Anything with the arches and the pouches, that is high yield. So please understand that. First archism, yeah. Cervical branchial sinus. I remember this coming up like maybe 2 or 3 times. The branchial sinus versus the fistula versus the branchial cyst. I remember this coming up. In the thyroglossal cyst, there were 3 to 4 questions where you had to differentiate. So the biggest thing, of course, the thyroglossal duct cyst and sinus, this is painless and it's mobile. Mobile. So when asked to move the tongue, the mass will move. I'm pretty sure I got that tidbit from Gray's. Branchial cyst, please know it's the second groove. That is very important, very important. So this is a cystic swelling along the SCM, sternocleidomastoid. That's a big, big, big one. And then branchial cyst is persistent at the second pouch and the cervical sinus. So you'll notice that this is a lot of, you see the pouches. Anytime you see pouch, anytime you see groove, please know that. What was that? Okay, so that was with that. So talking about pouches and stuff. So I wrote all this down. No. Oh, that's when my attempt to map all that out. I'm trying to find where I put the pouches because I know I whiteboarded that because I whiteboard everything. Oh, here. So I mapped this out. Oh, Lindsey. Know this, know all of it, know all of it, all of the arches, all of the pouches, know the cranial nerves that are associated with it. That's huge, huge, huge. Know the skeletal ones, know the muscles. No, I don't think arteries was a huge thing. And then the pouches. The big one is the thymus inferior parathyroid glands, and then the superior parathyroid gland. So third and fourth pouches, I would say, are the biggest high yield pouches. So that's big. And then I think they're going to ask you about every single cranial nerve with respect to their arch, honestly. Know those. Know those in some form or fashion if they're going to put that in there. Basal ganglion, I do not remember that coming back on NB2, honestly. Okay, I'm checking the chat again. I did use Gray's. I've been hearing some people say they got advice that Gray's wasn't the biggest thing, but I really, really, really hit Gray's hard and it did help. I do notice that it helped. FYI, I actually wrote out all of the questions on my whiteboard. I wrote out the answers to the questions on my whiteboard and then filled it in with my notes. That's how I studied the Gray's questions. And I do think it helped a lot, honestly. Yes, this will be posted. Okay, angio, yes, you will have a handful of the angio pics. I don't know if any of you guys have complete anatomy, but if you are having a hard time visualizing like the circle of Willis and all of the arteries, I would recommend going through complete anatomy because being able to 3D go through that and associate it with the cranial nerves in the different areas, I found that extremely helpful because it was so one-dimensional in the notes. It was so one-dimensional in the teaching, and it helped me so much. Yeah, I will pull that up. The imaging stuff, I'm going to pull that up. Exit points. Yes, exit points, the course of the cranial nerves, that is very high yield. Please know the places in the skull where they exit and where they course. Yes, you need to know the nuclei. You need to know the nuclei for all of the cranial nerves. You need to know the nuclei associated with different parts of the skull, I believe. So I am pulling up the actual PDF version of the lectures now. No, that is not what I want. And sites. That's not what I want. There we go. Ooh, give me lecture numbers because these are not labeled at all.
It was DLA 34. I
Okay.
can share my screen if you want.
Yeah, go for it.
I don't know if I can, but let me try. Oh, no, I can't. But yeah, it was DLA 34.
Okay, you should be able to share your screen now. I enabled it. Okay. Hold on. I'm going to request more remote control. Oh, it didn't work.
Sorry, I was on mute this whole time.
No, you're fine.
But here you go.
I'm going to request remote control of your computer.
Perfect, yeah. All right, here. Let
Cool.
me know if you want me to do anything.
I should be able to control it now.
Yeah.
Yeah, I'm controlling it.
Okay.
Okay.
If the box is in a way, I can move them.
You are
Zoom
perfectly
stuff.
fine. So I'm going to start at the top so I can orient myself. Okay, head and neck imaging. Okay, this stuff. Don't remember this being big. Oh, the sella turcica, all of those structures in the anterior part of the skull, that's important because if you, I don't remember if this was more NB1 or NB2, but if you have a like an MVC, a motor vehicle collision, it's one of the structures that is going to cause damage to the skull. Sinuses, did you guys do sinuses in NB2? Was that a thing?
Yeah.
Okay, you need to know those. You need to know those. If you don't understand it, Armando Hasudanon has an awesome couple videos over the sinuses, and so I would watch those. It was like a 2-minute video or something like that, and I understood sinuses so well. But you will have a couple questions. They should be easy for you if you understand it, but what drains to what, that's a big thing. There was an MRI coronal section that was on the exam, so make sure that you do understand the sinuses in that sense. So this is a really good schematic right here, because I mean, of what you would see on a coronal MRI. But all of these, I don't remember this being a huge thing. This is going to come back, the baseball to the eye. The baseball to the eye is definitely going to come back, and they are going to have an MRI image of that. And based on the presentation of the patient, you are going to have to know what is damaged. Okay, this is a really good example right here. You need to know the sinuses, and you need to know, oh crap, concha, sinuses and concha. You need to know all of that and what's associated with what. Nope. Nope. Know this picture. Know this picture. Because I studied it and then I forgot it. And the muscles, know the muscles if they label it. So medial lateral rectus, temporalis. Temporalis is right here. But please know these pictures. This one specifically and the muscles associated with it. Let's see, the sinuses. I don't think this view is important, honestly. This, again, oh, masseter, no masseter on this one. Lateral pterygoid, medial pterygoid. Yeah, know that. This is another big picture I would study and make sure that you can identify. The MRI stuff wasn't big with the tongue. It was more just a description or maybe cross sections of the tongue, but I don't remember the MRI being big with the tongue. But you do need to understand floor of the mouth is geniohyoid, mylohyoid, and anteriorability of the digastric. That is very important. So the tongue, the soft palate, the hard palate, all of that stuff is, you will see material over that on the exam. Common carotid and its association with the cranial nerves. I hope I'm saying that correctly, but that was a thing. That was a thing. Okay, you need to know this by heart. I'm sorry, but you do. This angiogram right here, please note the branches. I think we had lingual on ours. We had to identify the lingual one on here. This is going to be very, very, very high yield.
What number slides are those from the DLA, if it's telling you?
It's not showing, but I can like look it up later and put it in the chat.
It's 25.
Oh, awesome.
Thank you.
It's DLA 34.
DLA 34, imaging of the head and neck. This one was big on the lab exam, but it wasn't this, it was something else, but it was really big on the lab exam. It was peeled back on the cheek and you had to identify that stuff. This, of course, this was big in NB1, but please know MCA, PCA, ACA. This picture is also big. Please, please, please know MCA versus ACA. This one, of course, is really big. This is kind of the imaging that I used complete anatomy for with respect to its relation for the brainstem and the cranial nerves. Know the where the mammillary body is, where the pituitary gland is. Please know this anatomy because it will come up. All of this is pretty much same. No. No. Okay, those are just questions.
Okay, I can stop sharing.
Upper motor neuron versus the lower motor neuron of the facial nerve. Are you talking about cranial nerve 7? Facial nerve? I don't remember that being a thing with respect to upper motor versus lower motor neuron. Honestly, I'm not gonna lie to you. The biggest thing with the cranial nerves with upper versus lower motor is that trigeminal nerve, and it's if it involves the forehead or not. But I don't remember that being a big thing with cranial nerve 7. Honestly. Who did you guys have for your cranial nerve lectures?
We had 2 folks, I think, and it was like 2 different ways it was delivered to us. One, it was Dr. G, and the other one was Dr. Magoo.
Okay. We had Dr. Duplessis, and her slides were incredible. Like I don't know if you guys got the same slides, but they were like color coded, and it went through it all really, really nicely. But which cranial nerve is it? The one that goes through like 10 different parts in the skull. I know that didn't make any sense, but should be able to find this easily because it's so colorful. Okay, well, I can't find it in my notes. Y'all know what lecture that was?
Do you mean like the ones in the beginning or at the end? Because we had the clinical case ones, and then we had lecture like 39 and 40.
It was a lecture series of like 3 to 4 lectures, and it was just the cranial nerve. So it had like cranial nerve 5, 7.
Yeah, that's 39 and 40, because I looked
Okay.
at Brady's slides and yeah, they look pretty similar.
Did I just exit out? $39 and $40. Let's go find those.
Lindsay, I think I have them pulled up. Give me 1 second.
Oh, cool. Yeah.
Second.
Ooh, I got it. Oh, you got it.
You see this?
I do. I'm requesting control of your screen.
Go for it.
Come on. There we go. I'm looking for a specific thing. This is what I'm looking for. Oh my goodness. Okay, stop overshooting. You need to know this like the back of your hand. Please, please, please know. And these images are so good. I love these images because it makes so much sense. It simplifies it so much. Opening the foramen rotundum. That's 5. Oh, it's the facial nerve I want. Here. This one, maybe. You guys don't have the color. This. Know this. Please, please, please know this. So you need to understand at what area you are going to get certain symptoms with a lesion. And so they love to do the one with the chordae tympani. They love to do talk about the ganglion in here. That's a big one. Yes, lacrimal gland, greater petrosal nerve, that is extremely high yield. They will not use this image, unfortunately. They are going to more describe the patient case and expect you to know where the lesion is. Or they will say there is a lesion here at the opening or just above the opening, and which of the following functions would, which of the following symptoms would you likely see in this patient? That's a big one. And some of their choices might be the lacrimal gland, decrease secretions from the lacrimal gland, stuff like that. Okay, are there any more questions? We'll just do like by that. Just ask me your questions and we'll go through that. I mean, we have kind of been doing that, but just endorsing that. For ear, the biggest thing is going to be innervation. Honestly, they love the posterior auricular nerve. There's another one. I can't remember it off the top of my head. What's the other one that's over here? It kind of sounds like posterior auricular temporal. Yeah, those are big. Know those. Oh, okay. Sorry, my computer just went black for a second. For the lesions, honestly, grays, honestly. Ooh, the scalp thing, there will be a question. There was a really big, very long, very intense discussion on this. The scalp layers, yeah, we can go through that. It's actually pretty simple, but you need to understand there's a trick. They're not a trick. The way they word it is weird. Oh, it came up on NB2. We had the big discussion and it came up on another exam and we all knew the question because we spent like 30 minutes talking about it. But I need to go to my thing. Let me find it in my notes. And then I will be able to tell.
You're talking about the layers for scalp,
Yeah.
and then the loose areolar connective being the danger zone for that one.
Yes. But there's, here's a pop quiz. Which of the layers do you need to close so there's not a big gaping scar or big gaping wound? I know I probably just butchered.
And the aponeurosis?
It's the aponeurosis, yeah. Which is dense connective tissue, yeah.
Also, Lindsay, let me know if you need me to pull up any other lectures. For the
Okay,
time being,
thanks.
let me stop sharing.
Oh, here. Here's that. Okay. I'm gonna share my screen again. So scalp, you all know this is an acronym. So skin, dense connective tissue, aponeurotic layer, loose connective tissue, pericranium. Oh my God. So the big thing you need to know the danger zone. What's the danger zone?
Loose connective.
Yeah. So infections in this layer are going to spread And then connected to, but that's big thing. So remember, you always want to tie it back to a pathology. So that and then the aponeurosis are going to be your two biggest ones for the layers of the scalp, honestly. So skin is just contains hair follicles, connective tissue, dense connective tissue connects to the aponeurotic layer. So this kind of goes with each other, and this is what you have to close to make sure you close a wound properly. Loose connective, it's the danger zone, and then pericranium, so it's just the periosteum on the outer layer. So you'll have like one question over that. It's not going to be big on the exam. It wasn't big for us, honestly. The 3 fluid conditions at birth. Yeah, this stuff. So it's the difference that we did have one of these, and it was a CT. It was a CT or an X-ray. I don't remember which one it was, but you need to understand the one that is unilateral versus bilateral. That's going to be a big thing for you. So this one does not cross the suture line. The cephalohematoma does not cross the suture line. I remember this because a hematoma is kind of localized. So if you get a bruise and you have a big hematoma there, it's in one space. And so it's not going to cross the suture line. There is one in Grays. I know they have a CT or X-ray or something in Grays for this. Yeah. I think both of them will cross the suture line. And the reason is this is between the periosteum and the bone. And so the periosteum is closely associated with the bone. And so since the skull is made up of separate bones that fuse together, the periosteum is going to be associated with it. So it's between those two layers, you're not going to let it, it's not going to cross. Whereas the subgaleal hemorrhage, I hope I'm saying that right, is between the aponeurotic layer and the periosteum. So while these are layers of the skin, they're not closely associated with one another like the periosteum and the bone are. And so you are going to get that crossing the suture line. This was big. I just saw this in my notes and I wanted to point it out because this was a really big thing. The carotid sheath, the contents, you need to understand the contents and their relation to each other. So the internal jugular, which is anterior to the common carotid, and then vagus is posterior to both of these. That was a big thing.
I have a question for you, Lindsey.
Mm-hmm.
Do you remember how they asked y'all about the cavernous sinus stuff between both like the thrombosis and then also like the structures running through and if there was a lesion there or something like that? The thrombosis ones are kind of tricky in grades, I feel like.
Yes.
Because there's like the different routes. So whenever the answer is not the ophthalmic, then that's when it seems like it doesn't make a whole lot of sense.
So the cavernous sinus, 6 is the one that runs through. And on the outside, you have 3, 4, V1, and V2 on the lateral wall. So I memorized this picture and I was good for the exam. Does that answer your question?
I think she's more worried about the if there's an infection right at the nasal point, and then it goes
so they
backwards.
see like the person has acne and then that runs through their face and then they get an infection, the thrombosis.
Yes. They will ask you which arteries are responsible for that. Isn't that
just, the angular to the, or the like ophthalmic to the cavernous sinus, and then like to like the retromandibular, and then it can just like spread from there?
I think so. I don't remember off the top of my head. I just, now I know. I don't remember.
Because they really emphasize the pterygo venous.
The PT, yeah.
Plexus too.
Oof. I know exactly what you're talking about.
a lot of the questions have like all of the possible routes as answer choices, but some of them are better than others.
What
but then whenever-
happened? Who's
Oh my
there?
God.
No. My
What did
sincere-
you do, Brady?
My sincerest apologies. My dad's washing the house outside and he tripped the breakers of the house. So they're wet now. So every time I reset the breaker, it trips. So we had to hardwire everything to bypass the breaker. So I'm here now. So please continue. I'll let me get all set up. Sorry, Cassidy, for cutting you off.
Brady, I'm also recording in the meantime.
Okay.
I can send you the clips for this.
That'll work. No promises that first clip. I don't know where it went. It might have been lost. We'll have to try to figure that out. But
We've been going over random chat questions. That's what we're doing.
okay, great. Okay, just give me 1 second and try to figure out. All right, so let's assume that that first part was lost. Just in case people want to watch it, I'm going to quickly go back through.
Okay, let's stop sharing.
Okay, yeah, thank you. I'm going to quickly go back through just a few of the points that we made, just in case. I don't want anybody to miss out on that first part. And I do apologize, guys. Hopefully we won't run into any more problems. All right, wait, can y'all see the screen? Yes, okay, good. All right, so first I was mentioning, this is a good picture. It is from your notes, but it's also posted on my drive to kind of orient yourself to what goes through the ganglia. Remember, some things, primarily these parasympathetic fibers, synapse in the ganglia, but a lot of things track through it, right? So you need to know where it goes and where the terminal endpoints are. I pulled this is also on my drive. These are from Dr. Burkhart's little cases, just some important things just to kind of point out Weber syndrome, Wallenberg syndrome, and foveal syndrome. This was on our exam. We didn't think it would be, but it did end up being on there. So take a look at that. That's on the drive. I mentioned thyroid glossal duct cyst, midline, move with swallowing, cervical sinus cyst. I think it's maybe this one. It's off to the side and it does not move with swallowing. Make sure you can identify these on an axial scan, like an MRI. Remember, you would expect the thyroid glossal duct cyst to be midline. Okay, I did point this out. Know these different membranes, what travels in the carotid sheath, and also this bucopharyngeal membrane here is posterior to the esophagus and the trachea. They did ask us some sort of question regarding if you do an emergency tracheotomy, what you go through. I think it's the bucopharyngeal membrane, but double check that if y'all get a chance. And also, if the patient makes it to the ER, what they actually go a little bit higher up, because in an emergency situation, when you do tracheotomy, there's a lot of nerves there. So in the ER, they could actually take a midline cut and go higher up, avoid some nerves. It's just harder to get to in an emergency situation. So make sure you know what you have to travel through from the skin to the trachea in both situations.
Hey, Brady, what exactly is
Yes.
the difference between the tracheostomy and the tracheotomy?
I'm not. I think it is. I think it's technically called a tracheostomy. I might have said that incorrectly. I think I think it's a tracheostomy that you go through. No, tracheotomy is the emergency. We'll have to double check. Can somebody look that up? I'm not exactly sure. I think
tracheotomy is like the action of doing it, and tracheostomy is what you put in there. You're cleaning out. It's like it's the ostomy, it's the hole.
Right. Okay. Right. Like when the smokers like smoke through outside the hospital, right after they have throat cancer, they smoke out of the tracheostomy. Tracheotomy is the procedure. Thank you, Aaron. Okay. Yeah. If you ever see the patients who have throat cancer, they end up smoking out of the little tracheostomy. Kind of trippy to see that, but anyway. Okay. So what else? Ansa cervicalis is one of those tricky things. You kind of need to orient yourself to how that works. And how it comes off these cervical branches. We did have a lab question on that. Make sure with the lab exam, you look through those lab quizzes and can identify all the structures that you see. This is a good one. If you look at my abbreviated notes, you could see I took the nerve and what muscles it innervates. You need to memorize these because they could easily ask you if you have a lesion to C1, what muscles. are affected. So there's a recurring theme here that like the muscles of the pharynx, and we'll get to it in a little bit, the muscles of the pharynx are all innervated by one nerve except for one, right? Or the muscles of the tongue or whatever it is, there's always a one exception, which is kind of convenient because you can star that one. That's the one they tend to ask about, whatever that one exception is. But as we go through this, I'll try to point them out if I see them. Carotid sinus versus carotid body. Sinus deals with pressure, the baroreceptors, only cranial nerve 9. Carotid body is chemoreceptors. You deal with oxygen and pH. It deals with 9 and 10. Again, you could kind of, okay, so yeah, recurrent laryngeal nerve. Remember that if there is some sort of aneurysm to the aortic arch, you could press on this left recurrent laryngeal nerve, and that could cause hoarseness. So the patient will present with hoarseness. You want to examine the architecture of the blood vessels coming out of the heart to see if there's any sort of aneurysm or pathology. These nodes are, as we were saying earlier, a little tricky. It's not very intuitive reading through this. Just know that all the drainage points come from the face down to the end of the mandible and track down. We did see, these are important. Jugulodigastric deals with the tonsils. Jugulo-omohyoid is going to deal with the tongue. Okay, and that's that. All right, let's see what else. All right, quickly, we can look at these. Y'all should be pros at this now. Remember the cranial fossa. Sorry, hold on. The cranial fossa, you need to know what cranial nerves go through it, not just where they go through the crania, but where they actually go through through the ganglia into their terminal endpoints. So you can remember 3, 4, 6 in V1, superior orbital fissure, and then it's ROS, so V2, V3, and middle meningeal. As for stuff, it's kind of difficult to say what carries over from NB1 because it's kind of like a continuum of the spectrum of neuro, right? So there was stuff for NB1, but I was surprised in term 2 that there wasn't more stuff. I don't know if that means anything for you guys, because though y'all will probably get a ton of NB1 stuff. I can say this, we were adamant about the fact that we had a bunch of tracks on ours and y'all didn't seem to have so much. So if there are some stuff that carries over for from NB1 for you guys, maybe it'll be those tracks. Okay. Yeah, so this is the same DLA that was in the first NB1. So quickly, the arches and the grooves. So first aid has a good way of doing this. Like the first arch has to do with M's. The second arch has to do with S's. And then 3 deals with the common and internal carotid. Y'all do need to know 4 and 6 now. So those are going to be important. But as for the rest of this lecture, I think, or this DLA, I think if you know these, you should be good. And then remember, like the George syndrome is the one they like to test on in regards to these. All right. Grooves and pouches. The only really groove you need to know is the first one, obviously, the external acoustic meatus. Remember, it's cranial nerve 7 and 8 go through there. Pouches, these are the ones that flip. So pouch 1 deals with the ears, pouch 2 deals with the tonsils, and 3 and 4 flip. All right, so 1 is ears, 2 is tonsils, 3 and 4 flip. Meaning 4, the superior parathyroids come from 4, goes up top, and inferior parathyroids go from 3. So that's that. Face and scalp, again, it was one of those, I think, no, did he not do this one? Yeah, Dr. Haig did this one. So yeah, Bell's palsy, they love to test on whether you feel it on the scalp or not. So if you have Bell's palsy, which is a lower motor neuron, or a facial nerve problem, your entire contralateral face will be numb, right? You won't feel it, or you'll be paralyzed, yeah, because it's 7. But if it's an upper motor neuron, because there's bilateral innervation, you will be able to wrinkle the forehead. So they like to differentiate between those because that way, that's an easy way to tell whether it's Bell's palsy with a facial nerve problem or it's an upper motor neuron problem, meaning you can wrinkle the forehead. These are super important. I would be able to even identify these on imaging, right? So they could give you this sort of structure here. I don't even remember them off the top of my head. I think at some point they gave y'all a, maybe it wasn't this lecture, maybe it was in the embryology or something. They gave you a chart that had like what correlates with what. When we get there, we could talk about it because I don't really remember. These are going to be things that I would just do grays for this stuff. This is like straight anatomy. Yeah, this is good. 2 zebras bit my clavicle, right? So for the branches of the facial nerve, you do 5. For the branches of the trigeminal nerve, you do 3, right? B1, B2, B3, right? And that kind of tells you where the branches go. And if you have a general understanding where they lay, you could kind of tell what muscles they do. But once again, I would do the grays for those. If you could do the grays, you should be good. Facial nerve travels through the parotid gland, right? So if you have a parotidectomy, it does. The facial nerve can be injured, right? It's one of, if they talk about it, that's the nerve that's injured. It doesn't innervate the parotid gland; it just travels through it. I think the auriculotemporal is what actually gives innervation to the parotid gland. Let me pull up the chat just in case I say something wrong. Somebody can correct me. All right. Right. So yeah, for these, you lay 3 down. Remember, one of the tricky things is like this little arch of the mandible actually comes from those cervical branches. So I remember maybe it was a Gray's question that was really tricky because I was like, is that part of the mandibular? Or, but like, you see this arch of the mandible right here. Is from the cervical branches. Yes, so auriculotemporal for sensory and lesser petrosal parasympathetic for secretion. Thank you. All right, and then this kind of lays it out in a more detailed fashion. But yeah, you could see this cervical part does like that little arch of the mandible. Yeah, so yeah, I mean, importantly, external carotid and the branches that come off of it, facial, superficial temporal, and most importantly, that maxillary, because off of the maxillary, you get that middle meningeal, right? So that's where those epidural hematomas or hemorrhages come from. Greater auricular from the corner of the jaw, right? So from that, that cervical branch comes off there. And then remember, the internal carotid is going to dive through that carotid siphon and go into the brain. Branch is going to be the ophthalmic artery. So yeah, you should know those. This is a good little picture right here, the one down here that y'all could see. Veins, just know, most importantly, the cavernous sinus. Remember, if there's some sort of infection, some sort of sinus infection, it can irritate those nerves. Remember, they like to ask that question if you have some sort of aneurysm or infection of the carotid vessel, the carotid artery that goes through there. The nerve that's closest to it is 6. All right, so, and maybe there's a picture of it, but it runs really close to it. So it would be the first one. The abducens would be the first one that's affected. The other ones kind of lay on the outside. You don't need to know what comes next. It's just if that 6 is close enough to it. And this is probably a better image than that other one we looked at with the lymphatics. You could see that everything drains from the face to the jaw. So they could ask you a question, where would the parotid, the lymph from the parotid go? And you could say, it's down to the preauricular. Yeah, and then submental will drain underneath the chin. All right, yes, this question came up and we were all wondering about it, but think about it, right? So the layers of the scalp, say scalp, right? Skin, connective tissue, aponeurosis, loose connective tissue, and the pericranium. The question was, if you do sutures, how many layers do you go through? Well, it's through SCA. You go all the way through the aponeurosis, right? Because it's gonna help tug it together, right? So you want the first 3 layers. If you have to do sutures, doesn't really help if you're putting sutures through loose connective tissue. It's loose, right? So it's not going to do anything. You can't really go through the cranium. So the first 3 layers, but that was on our test. Oh, and definitely this too. The danger zone, because it's loose connective tissue, infections can easily go spread through that loose connective tissue. Yeah. And remember, these emissary veins are like those bridging veins, right? When you have some subdural hematoma and it kind of the brain atrophies and you have these lengthening of these veins. Oh, here we go. Yeah, this is good. Star, right? So these are the different ones. One of the good differentiators here is that cephalohematoma does not cross the suture line. Typically, when they say that, that means it's deep. To not cross the suture line, you need to be next to the periosteum, right? Because you need to be like involved with that underlying bone. So then that subgaleal comes across, and then that caput secundum is more of just an edema, right? So just under the skin. So I would know these. I would be able to identify these if they actually give you a picture of a child, right? And then know like the time span, because they could say the baby was just born. They have a big edematous area. So you could see that at the time of birth versus some sort of injury that may have been formed during the birthing process. Okay, let's see. Yeah, here we go. So yeah, definitely try to differentiate these and what we're looking at. Remember, if it doesn't cross the suture lines, it's deeper, right? You can see that there, it forms these little hump formations. Right, and if you could press on it like this, it's probably just edema, right? If you could press it and move the fluid around, it's not that deep like here. So yeah, be able to identify these. I wish he probably did point these out. I guess I didn't write them down when he was doing it. All right. I don't remember them giving us too many questions about the chemical senses, how that worked. But that's a great slide. Injuries, yeah. So the one they really like is the inferior aspect of the orbit, right? Because if you trap that middle rectus, inferior rectus, you can't look upward, right? You're trapping it. It's a muscle contracture or trapping opposed to an actual nerve injury. So that's what we're looking at there. They asked a bunch of questions that I'm thinking about it, the anastomoses of the nose. Like I just remember sphingopalantine sounds like sphinger, like a finger, right? And if you pick your nose, that's what tends to bleed. But they asked like about the anastomoses. I don't know that I ever really got them straight, but if you could write those out or know those, that'll be good, because they'll give like this connects to this or this connects to this, and only one will be right, but they're very similar the way they do it. These are really good. You need to know, star on this one, you need to know what drains from what meatus or what recess. Okay, so easy points. Most of them go to the middle meatus. So if you remember the other ones, you can know where everything goes. So it's just this where the sinuses drain. So definitely know those. Yeah, so this one, right? It doesn't even really tell you definitively what connects with what. Yeah, but when they ligate it, they tend to ligate the sphenopalatine because it's a good place where everything kind of comes together to stop the bleeding. But yeah, like we had questions like greater palatine connects to lesser petrosal, and one of the answers would be like greater palatine connects to the medial posterior nape. So like it was really close. The way they did it was kind of messed up, but just make sure you know how the anastomoses go. Oh, here's a good one. How's that go? Kesselback drives his Lexus with his legs. That's good. All right, so you can see that in the chat. That's a good one. Thanks, Emily. Right, and then you could see kind of, this is where the ROS, right? So cranial V2 is going to go through R, the rotundum. That looks like V1 going up through the orbital fissure, but the trigeminal ganglions where that V1, V2, and V3. split, and V3 goes through O, so ovale, and then S is the middle meningeal. So make sure you know those. Yeah, so yeah, this is something that they would ask, right? So the anastomoses, the nosebleeds, stuff like that. There's a whole lecture on the pharynx, right? Yeah, this isn't that one. But yeah, so the gag reflex, remember that afferent branch is from 9, efferent, the motor response is 10, but there's a whole lecture on that coming up. So, or is that, no, that's not this one, right? This is, remember jugulo-digastric versus jugulo-omohyoid, tongue versus the tonsils, right? Submental will go underneath. Oh, I remember a question we had. Lindsey, do you remember how it was like a picture, a cartoon, and it was pointing to, like, it was like the chorda tympani, or like the answer was submental, and like what does the submental come from? It comes from the, yeah, the chin. Yes, that is true. Like what branch? It comes from something. I don't know. That was the question.
Inferior
right?
alveolar.
Thank you. That's it, right? And inferior, thank you, Daniel. Inferior alveolar. That's what, when you go to the dentist, if they numb you, they just jam lidocaine in the inferior alveolar. Yeah. So, yeah. So that was the question. They were like pointing. It was a cartoon diagram pointing to the inferior alveolar, and it was asking what was the terminal branch of it, I believe. So yeah, that's good. Yeah, but that's what goes to the chin for sure. I don't think they asked a bunch of, I don't remember. Do you remember questions on the actual chemical senses of the nose?
Nope. Maybe one, but
yeah, no help there. As for this, they used to think that there were like different quadrants, like where all this went, but come to find out they're like mixed up. So it's not true. Textbooks are wrong. Yeah, these would probably be good to know the difference. Which ones are ionotropic versus metabotropic, salty and sour, and like what are the messenger systems? So these make sense, right? But sweet's going to be C-ant versus bitters, IP3. 3-neuron pathway, you would expect that because technically it's sensory, right? Special sensory, but it's still going to be a tertiary pathway. Goes through the insular node. We don't talk too much about that, or this primary gustatory concept. Cortex is around the insular node lobe, right? So again, I don't really think we were really tested, and this is just all that. Yeah. Which probably means y'all will get like 12 questions on it, the way that it goes. But taste receptors, yeah, that was just a quick one. Oh, did he? Is this is not, oh no, it's they are all over. Okay, so this is right. Yeah, they used to think they were, oh, this is it. Yeah, okay, so they used to think they were in quadrants, but they are all over. Right, it's just different for different people. Right, this is more of the same. Oral cavity. Gross. All right. Again, this is more like straight anatomy. So if you could do those Gray's questions, you'll be good there and kind of know where all these, where these muscles run. What is the one tongue muscle that makes you stick your tongue out? Somebody remind me.
Genioglossus.
All right, if you say so. Yes, genio, cool. Know that one. So like those differences, right? A lot of, but like one specifically will do that. So those are the things to key in on. Right, so remember the chorda tympani is going to go to the anterior 2/3, and the lingual is going to give sensation. Chorda tympani, special senses for taste. Glossopharyngeal is the back of the tongue. Vagus nerve is going to be very far back. Right, so this is, right, is this the good one? Yeah, okay, yeah, genioglossus protrudes the tongue. Palatoglossus. Is this the one, the very exception, like the one, like all of them come from 12 and palatoglossus comes from 10? I think that's correct. So yeah, so right. So like, yeah, it got red highlight. So there you go. It's crazy how fast this information just leaves your head, like after the exam. It's just not fair. All right. Oh, yes, that was a tricky question. We had one that was like, which gland leaves, yeah, this right here. Which gland opens at the base of the frenulum, right? That little middle piece. And I was like, definitely sublingual. It's like under the tongue. It's sublingual, and it's not. It's submandibular. I think I got that wrong in the test. Yeah. So submandibular opens at the base of the frenulum.
Both of us got that one wrong on the test.
I was like, you mean the sublingual area? Definitely sublingual, right? Piece of cake. Wrong. All right. And then it crossed by the lingual nerve. So any sort of resection, some sort of cancer, tumor in the submandibular duct, you're worried about this lingual nerve. And this is the sublingual fold, wherever that's at, probably a little lateral to the frenulum. Great little image here. Great little image here, right? So you can kind of track it out and see where everything goes. This is the parasympathetic innervation. So when you think parasympathetic, you're thinking of secretions, right? Primarily secretions, tongues, the glands, everything outlined for you. Lymphatic drainage, submental or under the tongue. Where's that omohyoid thingy? It's not here. That's great. Well, I'm up. Here we go. Yeah, so, and that's the further drainage of it. So I don't know, whatever I said earlier was jugular-digastric, jugular-omohyoid from the tongue and digastric. I don't know, make sure you know that one. I thought I wrote it in here somewhere, but I'm pretty sure we actually had an image like this. It wasn't this one. It was something like it. Hold on, if I see it, I'll let y'all know. All right, so here's another good exception. All muscles of the soft palate innervated by the vagus, except the tensor velar palatini, which is going to be from mandibular, right? So it got red. It's red because it's a big exception they could ask you about. Fortunately, the exams aren't like A and B or all of the above. They have to pick the one that stands out. So they'll give you all the muscles of the that are innervated by the vagus, plus they'll put tensor velar palatini in there as well, but y'all know that by now. All right, I didn't like this lecture, but we'll go through it. That's not good. All right, so barium swallow. If you haven't seen that, you could watch that on YouTube. It's pretty interesting to see the way it works. Coid in the trachea. Yeah, so Lindsey, wasn't there something? Oh yeah, right. So yeah, so this is important. If it's in the trachea, it's going to be, the coin's going to be like one end when you look at it. If it's in the esophagus, because the esophagus kind of collapses, you're going to see the entire coin. Pretty sure we had a question like this, right? So depending on if you're looking AP or the PA axis or the lateral axis, which one they give you, remember that the trachea, the coin's going to be this way. They'll probably give you the esophagus just because they're trying to point out the fact that the esophagus collapses, so that the coin's going to be this way, right? Right, so this is just the division of the different areas of the pharynx. Don't know that it was super important. Right, so things to point out here. So right, another good exception. Of the muscles of the pharynx, all are coming from cranial nerve 10 except stylopharyngeus. This might have been the picture. Does this look familiar, Lindsey, this picture? And then he started pointing to these and I was like, nope, no idea what you're talking about. Or this one, yeah, what's 3? Stylopharyngeus is probably this one. I was like, they all look the same to me. So yeah, that. But yeah, so again, another good exception here. But you know, if you want to make a note, just maybe memorize those if y'all get this similar question. Bucopharyngeal fascia on the outer aspect. Yeah, well, so we had, they'll give you that axial cut that I showed y'all. Oh, this one right here. Yeah, right. So look, if you swallow a coin, the reason you could see the entire circle of the corn on an anterior posterior view is because look how the esophagus folds, right? So when you swallow it, it's going to go wide, you know. Yeah, so good. Dread, except stylopharyngeus. Anytime I see exception, it's red. That means redness. All right. This is a lot of redness because it got a star to all muscles of the tongue. So yeah, like by all means, make sure you know this, right? These are your exceptions. These are what they can ask you. And you should run across those in grays too. This is a good little way of remembering these. Vitamin C and D for the branches. There should be a better picture of it. Y'all may have come across that. It's like vertebral something, internal something, I don't know. Yeah, they did put a muscle pick on the exam. It was a cartoon image of it. If anybody remembers these branches, I don't think. Anyway, they're the branches of the subclavian artery. So remember vitamin C, D, that is the order of them that one's vertebral, I forget the rest.
Vertebral, yeah. Internal thoracic, thyrocervical, and then costocervical, and then dorsoscapular.
You get a gold star. Thank you, Kishore.
And you also have suprascapular as well. And cervical transverse, I think, somewhere in there.
Are they branches of these branches? Maybe that's.
Ooh.
Yeah, let me see if we come across another image. I think it might have been like some sort of angiography that they showed all the branches. Not sure, but just yeah, this is a good little way of remembering it. But if we come across it in a more explainable fashion for me, then we'll look at it. Right, so yeah, so there's just a little bit of nomenclature here to be able to differentiate. Remember, those true vocal cords are going to come all the way across. The false vocal cords kind of like lay down in here. And then the vestibule is this area. I don't know that they necessarily give you an image here, but just some of the nomenclature to know it. This is good. Yeah, the only vocal abductor, right? Posterior cricoarytenoid. So it's going to help open this area of the larynx, right? So so you can breathe, right? Or so you can help to phonate, right? But some of these, like the cricothyroid, comes from the external laryngeal. These will help with your vocal cords. But this posterior cricoarytenoid, good exception. It's the only one that's going to actually open up or abduct that area.
Sorry to interrupt. So I just looked it up, and so the transverse cervical and the suprascapular, they are part of the thyroid cervical.
Okay, yeah, so they're just or in branches that. Thank you. This is good to know. So it tripped me up for a little bit. There are technically no motor that you need to worry about above the cords, right? Everything kind of dives down below it. So sensory above is going to be internal laryngeal. Below, everything's going to be recurrent laryngeal. So just compartmentalize that in your head. Everything sensory and motor is going to come from recurrent laryngeal. And of these, all the intrinsic muscles except the cricothyroid, remember that's going to be external laryngeal. So you just have to sit with it a little while and work this out. But those are definitely test questions, possible test questions. Yeah, so look, you can see the adduction closes, abduction, that's this posterior cricoarytenoid muscle that helps to open it. Yep. Right, so good exception there. All right. So yeah, recurrent laryngeal runs there. These kind of make sense. Inferior goes to inferior, superior goes superior. So that all makes sense. Nothing crazy there. And you see the internal laryngeal getting sensory above, recurrent does motor and sensory below. Oh, here we go. Right. So emergency access. I wonder if they put what you go through, because that was what our question was. It was like, what layers do you go through? Maybe not. Might be something to look at. Right. So cricothyroidotomy, that's the emergency one. So if they tell you in the STEM that it's an emergency. It's that if at any point, it's still an emergency if they make it to the ER, right? But if they tell you they're in the ER, they're actually in a hospital, then they're going to do the full-blown tracheotomy, right? So by doing this, you're avoiding some of the nerve structure, right? Yeah, and that's where they do it here. I might have said that incorrectly. So the first time, so the emergency one is above. I said the emergency one was below. The emergency one is above, and the one that they could do under, you know, in the ER is below, right? So the reason they don't do it above in the ER, apparently they get a bigger window, but there's some vasculature that travels under here. But yeah, an emergency situation, you find the thyroid cartilage and go right below it. But it's above, right? So I said that wrong earlier. The emergency one's above. The proper one in the ED is going to be below. Okay, so what is this? This is going to be in the esophagus, right? All right. Okay, a lot of stuff travels through here. You can see that it's just one of those things you kind of have to memorize or kind of have to know. As for the anatomy, I mean, I don't think they gave us anything like this and pointed to anything and asked us. It was more about just written out. Yeah, so you know this, ovale, right? The ROS, R is V2, O is V3, S is middle meningeal. And you can see here, yeah, the PT fossa, right? The gateway to the PT fossa. It's just, again, if you actually had a skull and you were looking at it in 3D, it makes it so much easier. Even those 3D apps don't really do it justice. So here's another good exception. Lateral pterygoid is the only one that opens the mouth, right? The other three close the mouth. So that's the good exception they could ask you about, right? You have more power closing your mouth than you do opening it. So that's why you need 3 muscles to close it, where only one will help you to depress it. And you can see that here. Remember, these are muscles of mastication, so that's going to be trigeminal, V3 specifically. Then the IT fossa, yeah, so again, just had it like it had in the beginning. You kind of just need to know what goes through there. They could really ask you anything. It's kind of a larger area here. Yeah, so this is important. So I do believe they gave us like an angiography of this. So same principle here, right? So you can see the maxillary artery. Then one of these is the superior or the middle meningeal. One of these two, maybe it's this one. Not exactly sure, maybe they have a better picture of it. Here we go. Oh, those are deep temporal. Maybe it's that one that dives through. Anyway, this is the maxillary, right? It comes off of the external carotid. You can see that here, goes, and then the middle meningeal, oh, here it is right here. This little tiny one goes in through the skull, into the foramen spinosum. So that's why when you have that epidural injury, right, it's right up against the that pterion where the bones come together, where the middle meningeal runs. And you can see here where the vessels run from the middle meningeal. I'm sorry, from the maxillary branch. Yeah, again, cavernous sinus, you're really worried about infection, so you can get swelling or swelling of the eye. These angular branches, you know, you can get some sort of, they often, I think there's some Grace questions. If you have a pimple on your face, sometimes it could go deeper, and you could get, you know, one of these branches can be affected depending on where the pimple is, and then it could drain actually into the cavernous sinus, which is a big problem. So yeah, just make sure you know those. Again, if you could do the Grace questions, y'all should be good with this anatomy stuff. And then the branches of the mandibular, remember, do muscles of mastication. Chorda tympani comes off of 7, remember, but whereas the sensation will come off of V3. And there you go, that's what they do, the dentist does, right? Numbs half your mouth. And then the pterygopalatine fossa, it's a little bit, it's a little bit deeper. So I think there's a whole nother, or this is the second part of that lecture, right? And then you can know what specifically goes through that. These are important structures, right? So you definitely want to remember those. I don't think they gave us anything like this, but yeah. These, I don't know, these are just, I don't know, I don't like these, but if that's jam, then memorize those or something. Right, so V2 goes to the pterygopalatine fossa, Vidian nerve. For some reason, they like that one, but it's the nerve of the pterygoid canal. I forget his name. He always talks about the Vidian nerve, the younger guy. Anyway. All right, again, more of the same stuff. The palatal branches, same thing. A lot of this, unfortunately, is just anatomy, but if you find a clinical correlate that goes with it, those will be good to know. Make sure you know the sinuses, where they lay, maxillary, frontal, ethmoid's kind of behind. Those are going to be important. All right, 5 and 7. Okay, so star, right? So these are going to be important things to remember. Where they come off the brainstem, what are the major branches? What are the ganglia? So you can make sure you know these, where they go. So again, a lot of root memorization for this stuff, which is unfortunate. And right, and then the divisions. Same thing. So we've kind of talked about this already, where they go. There's a good little mnemonic for these. Right, they could easily ask you one of these, but so make sure you know all of these, not just the muscles of mastication, but the other smaller ones as well. I think I sat down and actually looked at this because it kind of works out. So once you go through the dura, then you're into the cavernous sinus here, and you can see where everything goes, and it kind of lays it out. This is so V2 through the, or the PT fossas here, you see V2 breaks off into the foramen rotundum. And whatever way, if you're better at whiteboarding these out or whatever, or looking at them this way, whatever, just make sure you know that, you know, where everything tracks, especially 5 and 7, right? And then this is more of the testing. That's a bad day. Herpes zoster, right? What they could ask you this. Actually, I think we did have a question of this. So what branch is this? Right, that's V1. It's that ophthalmic branch, right? So they get to ask you that. More of the same. I don't know if they really, you know, I know those nuclei of the brainstem are a pain to learn. I don't know if they asked us too many of those, so I wouldn't spend too much time on that. And then star, so just like the trigeminal, this is kind of the breakdown for the facial nerve. Goes through the geniculate ganglia. And what travels with it, right? Or the parasympathetic branches, major branches, but these are what travels with it, right? Oh, this is great. Yep. I don't know if y'all had this on the last test or this test, but they do like, if you have different, they have a better picture of it. Maybe not here. You know which one I'm talking about. It has like 1, 2, 3, 4, like what?
Yeah, mommy already told him about it.
Thanks, mommy. Yeah, right. So if you cut it wherever you cut it at is the, I don't know, is where the lesion is, right? If they say you cut here, what is the lesion, right? If it involves 7 and 8 or just 8 or whatnot. And right, you can see that facial nerve tracking through. 2 zebras bit my clavicle. And then again, you could try to trace these through. This is for the facial nerves, goes through the geniculate ganglia, facial canal that you see through the bone, and then it gets to goes through the parotid gland, and then you get those 5 branches, right? So, and then the chorda tympani, remember, it travels with it. So like a tricky thing, I think these were in grades too, it says like for this, for example, so the chorda tympani travels with and then branches off. Sometimes they say, you know, sometimes it will, like for instance, oh shoot, I think it's the lingual. At some point, the chorda tympani or the lingual join together. So you have to watch how it's worded, because some join and go to the terminal endpoints, some travel and then split and go to the terminal endpoints. So it's like you have to watch how it's worded, because for instance, if they say, you know, what happens to the chorda tympani prior to it separating, then you know you're still in the facial canal, right? So if you come across those questions, just make sure you know what goes with originally and then what joins up later, because I think the chorda tympani and the lingual come together at some point. Yeah, chorda to lingual, yeah, like 3 or 4 grace questions. Yeah, that's what I was talking about. So that it gets a little confusing because they join together later and travel together. So yeah, and this is just more of the testing stuff. Yeah, oh, here it is. Yeah, the 1, 2, 3 thing. So depending on where you cut, what kind of problems are you going to get? Bell's palsy, paralysis of the entire ipsilateral or contralateral side, or ipsilateral. Sorry, it's lower motor neuron, so it's ipsilateral. If it was an upper motor neuron problem, it would be contralateral, but it would spare the forehead, so the patient would still be able to wrinkle the forehead. Remember, cranial nerves don't cross, right? So once it's cranial nerve, it's considered peripheral, and they're not going to cross, right? So lower motor neuron, you could see here, right? Whole face, ipsilateral side. Upper motor neuron, contralateral side, they could still wrinkle their forehead. Right, contralateral comes over here, ipsilateral comes over here. More of the same, a lot of that memorization. Yeah, remember these ganglia are where parasympathetic fibers synapse, right? So that's what makes it a ganglia. That cell body there is the parasympathetic cell body. Most of the other things, the motor neurons and whatnot, travel through it. They don't necessarily synapse. And then this is just in words, kind of what breaks down. But it's very busy. So specifically 5 and 7, if you know those, you should be good. Another nice summary table for what goes where. And it contrasts the trigeminal versus the facial. So that's always good. All right. So for 9 through 12, again, they whoever taught this did the same thing, gives you these nice little tables to check yourself, make sure you know what goes where. But as I said earlier, knowing the differences, the exceptions are going to be how you answer these questions. It's nice to be able to name the 7 things that go with this nerve, but knowing the one that goes with the other one is going to help you answer the question. All right, for 10, you can see that here, very important, vagus. Where are the questions from the clinical cases DLA? Was it, are you talking about Dr. Burkhart's? I don't know if that was a DLA or what, or if it was just cases. Yeah, so there were, I would do those, make sure you know them. What I had earlier, this thing, these were the things I pulled out that were specific in those that had to do with the specific symptoms, right? So if you can at least answer. We thought it was very low yield, but I'm pretty sure 2 or 3 of them came up. So this is on my drive too. You can look at that, but I would go through them and make sure you can answer those for sure. It's definitely worth it. And then some of the nuclei that come off for the vagus, what they do. And then we get into testing. Sure. So cough reflex. Remember, afferent branch here. So coughing is going to be 10, right? It's a little bit lower down. Gag is going to be higher up. Afferent's 9, efferent's 10. Make sure you have those straight. Uvula, right? So tongue lesions, you lick your lesion, so it deviates to the side of the lesion. Uvula deviates away, right? Because the muscle that's intact is going to contract and pull it. The muscle that is out is going to be lax. So the uvula goes away, tongue goes towards. Easy points. 11, remember it does sternocleidomastoid to the opposite way. So if you have an 11 lesion on the left, you're not going to be able to look right? SCM. Those are good. Those are in grades too. So But it also does the trapezius, the ipsilateral trapezius. And right, testing, hypoglossal, knowing, yeah, here we go, goes towards, yep, motor nerve except the palatal-glossus, that's 10. So those are good exceptions. And I think this was more of a lab exam type question. They could ask you something like this, but I don't know that right now it's going to be super important. Okay, let's see. Cortical bulbar, I mean, this was, fortunately, this is very complex, and it's like, how much do you actually need to learn from it? Let's pull it up. Yeah, remember the thing about the cortical bulbar fibers. Okay, so yeah, Lindsey's got a roll, so I'll try to look at the chat while we do this. Yeah, so she's running for SGA president, everybody. So holla, she's gonna win. When it gets to the general body, y'all could vote. If you're in SGA, of course, vote for Lindsey. All right. So one of the important things is that while the cortical spinal tract travels through the posterior aspect of the internal capsule, the cortical bulbar fibers travel through the genu. Genu means knee, so it's like that branch point right here in the internal capsule, that middle area. So they could point to that. The thing is, it gets really complex. That's why knowing these different symptoms from Dr. Burkhardt's stuff. So these are lesions where like the ipsilateral face hasn't, it's ipsilateral face and contralateral body. So like it's a lesion before, when these bulbar fibers travel downward or inferiorly, they haven't crossed. So if you know these, you can answer a lot of the questions regarding the cortical bulbar system. But sadly, it'd be easy if they all cross at the same level, like the cortical spinal tract, but they tend to cross around where the nuclei is. So you just kind of have to go through these, but knowing that the uvula and the tongue to the side, uvula away. And then again, this goes through Bell's palsy. So yeah, you can go through those. Development of the head and neck, great. Because that's always fun. All right, we talked about the arches and grooves. Okay, that looks important. Arches are mesoderm, grooves, acto, pouches, endo. I don't know if we had a question on that, but that stands out as something I would make sure to know. This is busy, but it's just like those charts, right? It just tells you what comes from what. Remember 3 and 4 here, flip. And then here's those same charts that were in that DLA, right? 1's ears, 2's tonsils, 3 and 4 flip. No crest cells, always know those. Yeah, no crest cells responsible for induction of skeletal elements. Okay. Yeah, neural tube defects, remember folate, super important there. Anencephaly is up top, spina bifida tend to be lower down. Or marrow, they use these interchangeably. Marrow is like partial development, and it's no development. Holoprosencephaly, remember we talk about sonic hedgehog gene there. So this is something like that came up in NB2 that was talked about at NB1. So if you want to consider that something that crosses over, yeah, it would be good to know. Microcephaly, what causes FAS would be the one definitely to know, but some other things, but fetal alcohol syndrome must be something for sure. And is this where we get into the sutures? Yes, this is super important. So if you prematurely close one suture, you're expecting abnormal growth the opposite way, right? So if you prematurely close the suture that's going anterior posterior, the sagittal suture, right? You close that one, you would expect growth. So somebody explained it to me really well, or had a good way of doing it. So if it closes anterior posterior, you're going to get growth anterior posterior, if that makes sense. Because if you close the one that's running anterior posterior, you're not going to get growth outwards. So if you think of it, it runs the growth is going to run parallel to the suture that's closed prematurely. All right, so if you close anterior, posterior, the sutures on the side, the coronal sutures, are still open, so you're going to have growth. So the growth runs parallel to the suture that's closed. And yeah, so, but some of them are a little more complex, right? So you have this abnormality here. I think they asked the ones that were straightforward, but they could give you a picture. So this is the anterior fontanelles, right? But there are two, so, but like, okay, so like, look, so this is prematurely closure of the sagittal suture, right? The one running anterior posterior. So you get growth in the parallel direction. All right, if you had we'll look at the coronal in a second. So you can see here, you would expect the sagittal suture to run this way, but it prematurely closed. So the head grows more this way. I think they could surgically go and actually reopen these. I'm not exactly sure. I think I remember.
Do you mean, Brady, by that, do you mean that you have outward growth from like the occipital and at the frontal or the frontal sutures in that sense? So rather than like it expanding like outward as it would down the middle, it just kind of grows forward and back.
Yeah, so like, or like I said parallel, but say the growth will be in the same direction as the suture that was prematurely closed. So this sagittal suture, it runs anterior posterior, it was closed prematurely. And so you get growth in that direction. Because think of it, the sagittal suture runs here, and if it's open, it controls outward growth, right? The coronal sutures that run sideways or laterally control the growth anterior posterior. So whichever direction the suture is prematurely closed is the direction of growth, because the perpendicular sutures are the ones that control that direction. But so yeah, so early closure, parallel growth to suture, right? So if you close this sagittal suture, which runs anterior posterior, you would expect growth in the anterior posterior direction. Yeah, so coronal sutures run laterally. So if you close those prematurely, you will get lateral outward growth, right? Because this anterior posterior controls the lateral growth. So you get a wide head. There you go. Plagiocephaly is one, right? Or one side of the skull. Yeah, coronal suture on one side. So you expect this on one side, this ipsilateral side. They could ask about this. What would they ask? Oh, herniation of the cranial contents. Yeah, this encephalocele. I don't think they would give you some sort of ultrasound like this, but good to know here. Cranium bifidum. Oh, and then this is sort of similar to the spina bifida with meningiocele. Meninges means the nervous structure. I'm sorry, not the nervous structure, the actual meninges, right? So the meninges is going to come out. And then encephalocele means there's brain actually out too. So you can see that here. So skin, part of the meninges obviously has to come out, and then CSF in the brain, right? And yeah, obviously, as a lot of times it is, the longer the word, the worse it is. And then meningiohydroencephalocele, so you have part of the brain and part of the ventricular system that goes out too. So if you break it down, you can see meninges, so the meninges, the ventricular system is hydroencephalo's brain, and it's sealed off. So Arnold-Chiari malformation. I always get this confused with Dandy Walker. Oh, so this is inferior. Dandy Walker's absence of the cerebellum. This is inferior displacement of the midline, the vermis, through the foramen magnum. So this Arnold-Chiari malformation can cause an obstructive hydrocephalus, right? Can't get, if you squeeze down on the foramen magnum, you could pinch off the ventricular system, so you can't get, like you could see here. So the CSF can't go through the cerebral aqueduct and stuff. And you could see that here. So yeah, you could see that. They could actually give you a picture like this, right? You can appreciate that part of the cerebellum is actually being pushed through inferior displacement through the foramen magnum. Again, yeah, this is more of what happened in NB1 hydrocephalus. You would expect the ventricles to be enlarged. Transillumination, you can see that here, right? So some sort of obstructive hydrocephalus, I imagine, causing this high pressure. Yeah, I don't know that I even bothered learning this. I don't think this is super important, but you know, take that with a grain of salt. I don't know. Oh, here we go. This is where it gets good, but important. So the intermaxillary segment, when we start talking about cleft lip and cleft palate, right? So you can have a primary palate problem or a secondary palate problem. So I don't think they'll give you images of this. They might just use it in words, right? So the primary palate comes together from the intermaxillary segment, median palatine processes, right, to fuse, and it fuses at this secondary palate down here after it comes together. So you can see the intermaxillary segment fuses with the maxillary processes. So you can go through these, you can see the secondary palate here. So as long as you have a good understanding or a good definition for what goes with what and what's supposed to come together, you should be fine there. Right, so, oh, is that all? Did they go through this again sometime? Maybe it was one of the, maybe not, I don't know.
Yeah, there is another lecture for the
Okay,
class.
yeah, I thought, okay, thank you. Let's do the other head and neck, and then we'll go back to the autonomics. All right, okay, good. So here it is, yeah, the clefts. So yeah, so that midpoint is that incisive fossa, yeah, incisive, I guess, incisive foramen, that little area that could form, makes the fossa. Primary palate, the intermaxillary segment has to come together. Secondary palate are these lateral processes. And then you could see here, so even if they did give you a picture, you can appreciate what it would look like here. Anterior part, obviously the anterior part of the face, get that cleft lip and cleft palate. Failure of fusion of the lateral palatine processes to meet up, right? So this is a problem with the anterior fossa. Posterior is going to be back in the secondary, and you can see that here, the lateral palatine processes to meet with each other. So whereas this is lateral palatine to meet with the primary palate, you get a problem there. This is the secondary palate not fusing together. Now, and you can get both if it is possible to get both. There was one where there's like a midline one. Is it when the maxillary prominences? I think there's one that's midline. Maybe
That's median cleft lift.
Oh, this one, yeah. Right, so yeah, thank you. The formation of the intermaxillary segment and its midline, but let me go back real quick. Right, so it just kind of goes into the different variations of it, but if you just know what's supposed to join with what, you should be fine because you can work these out. Yes, unilateral, but it's on the side. So the intermaxillary segment has already joined together, so you're not going to have a midline problem. And then it's supposed to join with the left maxillary or the maxillary processes. So if it's a problem, so you can see that here, the maxillary prominences to the intermaxillary segment. Whereas if it's median, it's a problem of the formation of the intermaxillary segment, the two medial nasal prominences. So those come together first, and then the lateral prominences join, and then the secondary prominences join together. So it depends at what time frame when this actually happens to determine how bad the cleft is. Yeah, okay, that's not that important. Oh, and then, yeah, so this is really sad. So yeah, if it's a maxillary prominence, right? So it's up above with the lateral nasal prominences. It's nasolacrimal groove that forms. And then the sinuses or the tongue. Yeah, so you already know this, right? The derivation of the anterior versus the posterior tongue. Let's see. Yeah, so it's kind of what they were saying in I don't know how super important this is. This is just kind of the last few pictures and words. So again, just knowing those exceptions are going to be really important. And then finally, we get to some diseases. Diseases are always important. So Treacher-Collins syndromes, very similar to Pierre-Robin sequence, because they're both first arch problems. The way I understand it is Treacher-Collins is a more advanced form of Pierre-Robin's. So knowing some of the exceptions that differentiate the two, I believe Treacher-Collins is the one that deals with conductive hearing loss, whereas Pierre-Robin's does not. Yeah, and Pierre-Robin's has that micrognathia, right? So the improper development or of the chin, and the cleft palate doesn't look like Treacher-Collins has cleft palate, so that would be specific for Pierre-Robin's. And of course, failure migration of the neural crest cells. That's Treacher-Collins. So be able to differentiate these, find the little things that differentiate the two, and you'll be good there, but they both deal with the first arch. We kind of talked about these. We talked about these in the beginning too, right? So remember this cervical sinus or this branchial sinus. Sometimes they use that. Don't get that confused with brachial. It's branchial, means cervical. Cervical sinus can form a fistula. It's going to be on the side. It's not going to move with swallowing. And you could see, right, I wish they had a picture, a better picture. Yes, here it is. Okay. Yeah, so you could see that here, right? So first off, whatever you're looking at scans, you divide it in half and you try to see what's different, right? They should be symmetrical for all intents and purposes, except like the GI system. But so it should be symmetrical. So this stands out, right? So it's not midline. If it was thyroglossal duct, it would be in the midline. So this is a cervical or branchial cyst that forms on the outside. So persistence of these sinuses, right? Or the second pharyngeal groove. And yeah, it runs right along the sternocleidomastoid, anterior to it typically. All right, and then remember the thyroglossal duct cyst, it's supposed to obliterate, but if it stays, it's going to be midline and it's going to move with swallowing. Those are the things that make it stand out, or in questions at least. Painless, oh yeah, they often say painless too, right? Movable mass with swallowing. Yeah, so look, this is good. This is what we had on our test. Put a star on this slide. Midline, thyroglossal. I think we had this exact picture on there. It was midline versus, remember, slice it in half. What looks different? This big thing right here. So that's the cervical sinus. All right, parathyroid glands, right? PTH. Yeah, I don't know if they'll give you anything with this. This is more endocrine and stuff. All right, cool. Now let's go back and look at autonomics. I think these who taught these? Mandolini. Yeah. So right, remember, this isn't stress. This is just autonomics. So a lot of this is review for you guys, the autonomic system. But it's one of those things like neuro. You could learn this stuff for 10 years. Like they have to kind of bring it down to our level and teach it in a few lectures. So it's like, how far do you go into it? But even these are blue slides. I know some people are like against these blue slides, but if you read them, they actually have a lot of good information. And they say it's like extra, but you'll find a lot of the questions come from it. So I do take the time to read these. I find I can get a lot of explanation because, of course, the more you understand, the less you have to strictly memorize, right? So where was I? Oh yeah, these. Make sure you have a good definition for all these. Easy answers on the test, or easy questions if you know what does what. And then there's more here. So they all have endocrine type functions. Pineal gland, melatonin. All right, and this is just kind of where they lay. I think more importantly, just having a definition for them would be fine. Yeah. Skip this slide. It's great to know, but The history of medicine, if you had time to learn that. All right, I don't know that we had too much about this. Doesn't mean don't know it, it's just I'm saying that I don't know that it was super important on our exam, but it kind of lays out like solitary nucleus versus the periaqueductal gray. But again, it's kind of one of those things like, how do you write a question about this? You know, like a clinical based question. So maybe not so important. Oh, I had a great, me and my friends still remember this forever. Y'all are gonna laugh at me on the inside. So where is it? It's like the hot and cold.
It's a DLA.
Okay, we'll get there, yeah. Remember this though, if you have some sort of infection, the first area that's going to be affected is the part that's adjacent to it, right? So if you have some sort of infection up here, the paraventricular area is going to be affected first. So it kind of just asks you where they lie, right? So the most medial aspect of it is going to be what's affected if you look at this ventricular system. So in case they ask you that.
Just out of curiosity, Brady, did they, in lieu of like, actually, oh, this is perfect, the slide you're on right now. So in regards to the lateral aspects of the hypothalamus, which I know give rise, or the paraventricular, which give rise to like things like the parvocellular nerves, did they ask you a question, like a lesioning question about something like that?
I can't remember off the top of my head. I think I just remember them talking about some sort of infection and it being like the first area that's affected. And it's like, well, it's the one that's adjacent to it, you know, like as it moves in. I can't remember off the top of my head. This is more of like that endocrine stuff. This, yeah, so, I don't remember off the top of my head. Yeah, more definitions. Got a star, so it must mean something. Yeah, so I mean, yeah, like so magnocellular, right? Again, this is SADPOX was the mnemonic for these. Supraoptic nucleus does ADH, paraventricular nucleus does oxytocin. So yeah, that would be good to know or to remember from endocrine. I think the next one's about stress. So this should all be review for you guys pretty much, right? The gonadal axis obviously is estrogen, testosterone. Let's see, yeah. I can't remember. I kind of feel like there was some silly question about this, but it may have been in the Sakai questions. Not 100% on that one. Right, okay. So again, a lot of this is review when he talks about the pituitary. So let's see. Oh, these were those DLAs. Let's see, I think, okay, so when it comes to feeding, decrease in feeding is going to be more of the medial, whereas increase in feeding, if you think of the medial aspect, decrease in feeding is skinnier, fatter would be on the outside, right? Increase in feeding. So you could think of it that way. Yeah, so if there's some sort of lesion, you know, it could lead to obesity, right? Medial, skinny, lesion there, lateral, big, lead to obesity. So that's a good one. These were those definitions that we looked at prior. So if you know those definitions, you know those are osmoreceptors, water regulation, or solute regulation. Yeah, more of the same. So these go into those definitions. So diabetes means are loving water, right? Diabetes insipidus, whereas diabetes mellitus is sugar loving, right? So this means you're always drinking water because you're always peeing it out because you don't have ADH to keep the water. So, oh yeah, so, all right. So first of all, so the anterior hypothalamus, if you're hot, the anterior hypothalamus will tell you to decrease your temperature. It's not saying it's it's not saying you're recognizing a decrease in temperature. It's saying if you're hot, it's going to go through methods to decrease your temperature, such as sweating, right? So make sure you understand that concept. Whereas the posterior hypothalamus, it was like, we used the way to remember, it was like hot booty. You got to have a hot booty. So posterior hypothalamus will cause you to increase your temperature. So it's an action. So if you're cold, you go through measures to increase your temperature, right? Hot booty, posterior to increase your temperature, such as shivering, right? So it's the action, right? So you recognize these centers recognize it and go through the action of doing something, right? So it's gonna, if you're hot, so they can ask you that, so don't get it tripped up. If you're hot, you're gonna activate your anterior hypothalamus to decrease your temperature. If you're cold, you're gonna activate your posterior hypothalamus to increase your temperature, okay? Because those are easily tripped up. Yeah, if you ever look at my notes and you see my ridiculous mnemonics, yeah, you know, it's probably my friends, don't blame me. They're the ones that are dirty, so I can't control that. They don't listen to this, so it's all good. Okay, again, right? So if you recognize you're hot, you're gonna go through the process of decreasing your temperature. But if you're cold and you have a lesion in the posterior area, you're not gonna be able to increase your temperature. You're not gonna go through that process. So just, yeah, and that could lead to hypothermia because you can't heat yourself up. Same thing for the other side, can lead to hypothermia if you can't cool yourself down. Again, see, like this isn't exactly, doesn't really tell you much. I mean, it kind of explains it, but if you just read these blue slides, it kind of just lays it out for you. So they are beneficial. Bladder control. This is more FDM stuff. Remember, the detrusor muscle is parasympathetically controlled, whereas the sphincter is sympathetically controlled. So, so we're just doing the drugs to deal with BPH and stuff like that. So, but yeah, this is pretty straightforward. You've learned this stuff already. So maybe just add a little bit on there. The Pontine Nutrition Center helps to navigate the you being able to urinate. All right, and then yeah, make sure you know these. Start on this one: automatic bladder versus atonic bladder. Automatic bladder means there's a lesion above S2 to S4, right? So you have a lesion above this, so you're not able to control it. So you keep voiding. You're not able to hold on to your urine, right? So you're automatically, you keep voiding, right? And atonic bladder means you're not able to void. So because it's atonic, it won't contract. So that means you have a lesion in S2 through S4, which, remember, parasympathetics are craniosacral. So S2 through S4 controls your parasympathetics. Parasympathetics are going to let you urinate. So if there's a lesion in the parasympathetic area, you're going to have an atonic bladder. It's not going to work. It's just going to fill up, so you don't get any reflex telling you your bladder's full and you need to urinate. Okay, organ, what was this about?
Question, Brady.
Yes.
Make sure I understood what you just said. For the automatic bladder, you said constantly, are you constantly peeing?
Yes, think of it, it's automatic. Like you just keep going, you can't control it, right? Just automatically go all the time. Atonic means like no contraction. Tonic means contract, A means no, so you can't contract your bladder. So there's a problem with the parasympathetic system. Parasympathetic system helps you contract the bladder, so it's atonic.
Got it. Thank you.
Yep, no problem. Reproductive control, I don't know, it's a couple slides. Yep, point and shoot. Yep, erection, ejaculation. Erection, nitrous oxide, right, helps to vasodilate. The vasculature, ejaculation is the alpha 1 response. That's more term 4 stuff. Y'all love that. All right, autonomics and stress. Remember, this has a lot to do with cortisol. Cortisol is the long-term response to stress. When you have high levels of cortisol, it tends to make you hyperglycemic, but it can also make your immune system decrease because cortisol has that effect of decreasing the immune response. So knowing these different axes will help Knowing what does what, I think they outlined it a little bit better coming up, if I remember correctly. So yeah, again, it's just that axis that you talked about in endocrine, right? Where you're trying, basically activating cortisol. Remember, catecholamines is like a fight or flight and an acute reaction to stress. So you're gonna release catecholamines. Cortisol is a more long-acting stress, right? So you're gonna have like increase, hyperglycemia, decreased inflammation, right? Your immune system. Whereas the catecholamines, I always think of running from a bear, heart rate goes up, it's immediate, right? So, and you can read about that here. Oh, and that's, nope, wrong thing, sorry. All right, right, and that's kind of what I said, this acute fight or flight, amygdala being your fear center, helps to activate that. If you see a snake and you're scared of snakes, you get hyperactivation of that. HPA axis, so it's going to be that acute response to it. And then we talked about this kind of acute being catecholamines, chronic being more of a cortisol, cortisol response, right? And yeah, I don't know that this was super important. Just the idea of prolonged stress, increased cortisol, those actions of cortisol, if they're prolonged, they get exacerbated, right? So keep that in mind. Hyperinsulinemia, why? Because cortisol gives you hyperglycemia. So if you're always hyperglycemic, you're always going to have increased insulin, and it can be related to type 2 diabetes, right? Coronary artery disease, increased lipids floating around, get increased atherosclerosis. Impairs with, it impairs your sleep. Yep, for sure. Reproduction also has an effect on GnRH, excess glucocorticoids. Right, so it'll affect your libido and lead to ED and decreased fertilization. So yeah, don't be stressed, obviously, you'll be fine. Yeah, and these are kind of straightforward, right? Exercise, right? Anything that's going to decrease stress will help with your stress. All right, we did that. Clinical head. I don't plan on doing the psych stuff. I feel like it's pretty straightforward, but because we're almost finished the neuro stuff. But if y'all have questions about psych, I don't mind talking about it. All right, clinical head and neck. Right, so these were important because, these finally, we talk about clinical aspects, right? What's going on? Always try to make a habit of trying to figure out what words mean. Sometimes it's easy to skip over them, but if you make a habit of writing them out, the Latin gets easier when you start doing it, and it becomes second nature to you. So, right, so what are we talking about here? Looks like some sort of, at least here, it looks like some sort of cavernous sinus infection, right? Look at this, that's the cavernous sinus. Yeah, and you can see it's all infected, right? It can lead to periorbital edema and stuff like that. You could see that here, cavernous sinus infection. So anything that travels through it, it's likely to cause infection. A lot of times, how did she get it? Does it say? No, it doesn't really say. But like I said earlier, sometimes popping a pimple can lead to a venous drainage into the cavernous sinus if it's too deep. Yeah. But it could obviously come from the other way too, right? It's through the carotid artery. So venous drainage is going to come from the face. Carotid artery is going to be going to the face. And then importantly, it's got a star, cavernous sinus syndrome, right? Anything that travels through there can lead to a problem with it. All right, and then this is just more of the same. You know this, everything travels, yeah. But this is good review, right? So these are like clinical applications. So I like these. This is like a nice, easy diagram of like what goes where. It's like, why didn't y'all give us this earlier when you were giving us the diagrams with 100 things on it? Herpes zoster, right? So after you get chickenpox, herpes zoster or the HSV lives in your dorsal root ganglia. So if you're immunocompromised, typically older people, you can get some sort of reinfection, a latent infection, right? Latent meaning it was there for a while, just hanging out, and it got reactivated, right? So you can get depending on where it is, usually you'd see like a dermatomal distribution on the chest or whatnot, but it can obviously be in the face. We saw that picture of that older lady that had it in this lady. Yeah, maybe not the same lady, but yeah, it typically happens to older individuals. All right, and that's just a great way of testing. Do you know where all the branches go?
Brady, for the clinical case lectures, would you really just recommend reading through them and understanding like the condition for the case and like what nerve was being affected? Okay.
Yeah, because when in doubt, when people ask me like, I don't know what to study, what do you study? I always, my first answer is always start clinical, right? We're going to be clinical doctors. So focusing on the clinical stuff and then work your way down. So I actually like these lectures because it lets you start on a larger picture, gives you an umbrella idea of what's going on. We have a herpes zoster infection. Now let's kind of dive down into what's going on. So these are good ways to test your knowledge, right? Okay. We kind of, yeah, no problem. What is this? Right chin, lower chin, normal speech and chewing. So the mental area, no problem with phonation or muscles of mastication. Okay, great. So yeah, remember I was saying that this is where the dentist numb you up with the lidocaine, right? So you can get an injury there. And remember, like you were saying, this branch comes off the inferior alveolar submental. So if you get numbness of the chin, maybe it was some sort of dental problem. Remember, if they ever, like this is coming up again, like as we're talking about some in term 4, a lot of infections. If they ever tell you in the question that they've recently gone to the dentist, like 90% of the time, they're not telling you stuff like that just because they felt like it. Right? Like if they tell you they went to the dentist, it probably means something happened there, right? So you should key in on those types of things. Even when you're looking through this, like when I saw this, my first thought would be like, that's something with dental related. If they give me a dental question, I'm trying to think of something there. So it's again, trying to compartmentalize things in your head. Ovale, oh yeah, so this is good. The otic ganglion, and this is a good little mnemonic or way to remember it, V3. Accessory meningeal lesser petrosal and emissary veins that go through there. So that's a good way to know that. Again, kind of broke it down so you could see what goes where. This color means it's mixed. Yeah, and then you can see the different branches. All right, so displaced outward and downward. If the eye is down and out, what are you thinking about? Probably a cranial nerve 3 problem, right? Yep, eyes down and out. And what else is going on? So we know what travels with cranial nerve 3. Parasympathetics, the eye's dilated. You knock out parasympathetics, the eye's going to be dilated. Also, you're getting ptosis of the lid, that superior, what's it called? I forget. You know what I'm talking about. The little muscle that holds the eye up there is also travels with the cranial nerve 3, the oculomotor. So if the eye's down and out, eyes dilated, and you get ptosis, unilateral ptosis, you are thinking a cranial nerve 3 problem. Let's see. Okay, so, right, so lumbar puncture shows bloody CSF. Remember, before you ever do a CSF problem, if it's suspected, you want to get a brain scan. If there's some sort of increased pressure in the brain, jumping directly into doing a lumbar puncture is a good way to get a malpractice suit. So when in doubt, get a head scan, make sure there's no bleeding, and then you could check lumbar puncture and see if there's any blood. Not terribly important, but just illustrating the idea that make sure you get a CT of the head before you start doing a lumbar puncture. Don't know how they would ask that at a question, but this is a good thing to remember going forward. All right, y'all done this in NB1, knowing is it coming off the vertebral versus is it coming off of from the carotid artery, right? So remember, oculomotor nerve is often affected when you get some sort of herniation. Uncal herniation affects cranial nerve, whereas some sort of pituitary tumor can cause injury to cranial nerve 2, that bitemporal hemianopia. And right, so you could see 2, that pineal gland runs right under the optic chiasm, so pineal gland, the pituitary gland. And then so if you have some sort of tumor or lesion there, it can cause bitemporal hemianopia. And then cranial nerve 3, you can see here, if you get uncal herniation, it'll pinch on that ipsilateral oculomotor nerve, eyes down and out, eyes dilated, and then there's ptosis. Yes, all right. Same thing again, this is neuro 1 stuff. So super important. One of those things, it's like, why are y'all telling us this now? It's like, if you knew what correlates with what, I try to point that out in the first one. Anything PCA is 3, superior cerebellar 3 and 4, ICA's a little bit lower down coming off the basilar. So 6, 7, 8, pica comes off of the vertebral 9, or sorry, 10, 11, maybe even 9, I'll put that there. All right. Not super important, but they're not terribly difficult. Saccular is going to come off. Fusiform goes all the way around the vessel, and giant is kind of like a big saccular one. And then dissecting goes through. Typically, you look at those when you talk about Marfan's and the abdominal aorta. All right. So importantly, remember, a lot of times these aneurysms happen at these little branch points, these communicating arteries, because these large arteries are high pressure system. So if you go from a high pressure system and take a right angle into a communicating artery, oftentimes you can get an aneurysm. Anterior communicating artery being an important one. So remember that the optic nerve kind of sits right around there. You can see it here. So if you get some sort of lesion there, you can affect your vision as well. All right, guy, end-stage renal disease. He's on dialysis. Swelling of the left neck. Drooping upper eyelid, contracted pupil. Oh, he's got, what's it called? Horner syndrome. Yeah, so you knock out the sympathetics. That's why you get the contracted pupil, unopposed parasympathetics. Drooping up the upper eyelid, there's a sympathetic component to keeping your eye open as well, along with the one that travels with the oculomotor, and no sweating, anhydruria or something like that. You know what I mean? All right, yeah, so that's knocked out sympathetics. So yeah, that typically, anhidrosis, thank you, Sarah. That's what I meant to say. All right, so Horner syndrome, right? Knock it out on the ipsilateral side. And these are the 3 things you need to remember. If you knock out the sympathetics, you're going to get constriction, ptosis of that tarsal, and anhidrosis. There you go. All right, and then just some more of these diagrams that y'all love to look at. All right, imaging. We can look at this real quick. This is more of the same. Y'all have seen all these pictures already, basically. Again, if you're looking for some sort of pathology, some sort of fracture, divide the head in half and look for some differences. All right, make sure you can identify the sinuses. Typically, they're lighter, or they're darker because they don't have, this is their air filled, right? You can identify the sutures as well if they give you a picture of a kid. But as for diving too deep into these, it is a little difficult. So you can see the frontal sinus is darker because it's air filled. Yeah, so again, trauma is this where he talks about the lower aspect. Yeah, so like this is the lower aspect of the eye orbit. Black meaning air-filled maxillary sinus. So if you had a fracture here, you might have impingement of this inferior rectus muscle. And just more laying it out for you if you wanted to go through that. Again, look at the differences here, right? But it is difficult because it may be just a trippy cut. It looks like you got part of the concha there as well. Yeah. So again, I don't think these are super important. Maybe when you get to the lab exam, it's important, but you want to look for pathology here as well. Actually, you know what? Now that I say that, I think we did have a picture. It was this one. Yeah, we had this picture and it was pointing to the masseter and it was asking what muscle. So yeah, maybe just go through and make sure you can identify the big stuff here. But that was a question. It was masseter. It was pointing over here. Common carotid, remember it's going to be smaller. It travels medial to the internal jugular. The vein, the drainage is going to be it's going to be larger. Right. Oh, this is that one. Yeah, so this is a good one to know too. Make sure you can identify facial comes off. So this is the external carotid. Maxillary is going to come through. So you could kind of see, you could see the outline of the back of the head, the lower aspect of the mandible here. That's the mouth right there. So facial is going to come down right around the lower aspect of the mandible. Maxillary is going to come across the middle of the face. Superficial temporal is going to come on the outside. Occipital goes towards the back. So when you're looking at this, first thing to do is try to find which way the patient's facing. Eyes over here, back of the head over here. And then the superior thyroid is going to be the lower part. So yeah, I would definitely know this one too. Lingual is going underneath. Look, that looks like the chord of tympani right there, coming off the facial, joining the lingual, come down. So that's probably what that is. Or actually, sorry, it has to be a vessel because it's lit up. Sorry about that. But actually, the chord of tympani does come off the facial nerve and go travel with the lingual nerve. But this is obviously a vessel because it has dye in it, not a nerve. All right, more of the same, external carotid. Some anatomists like freaking out poor medical students. Okay, so that's a good way to remember it. So, yeah, you can work. The A is for ascending pharyngeal. I guess it's not labeled. I guess they don't go in order though, but these are the branches. Yeah, you know this by now. Carotid sinus, the siphon through the cavernous sinus, the carotid artery branches to the ACA and MCA. So yeah, these can definitely come back on this test. Remember, ACA is going to run midline. If you look at the homunculus, the legs are up in the midline area. The middle cerebral is going to be towards the outside, right? This, right, the face, the arm part of the homunculus. The pica, remember, goes to the back part, comes to the base vertebral artery, to the basilar, get to the posterior cerebral artery, and all those branches that come off. Remember the cranial nerves that are affected when you have a lesion at some of these. We talked about those. All right, just a different view of the vertebral. Remember, vertebral comes to basilar. Pica comes off the vertebral, ica comes off the basilar. The last branch is posterior cerebral, and right below it is the superior cerebellar, right? So cranial nerve 3 runs around there. It could be affected, 4 could be affected. Around the ica, you're worried about 6, 7, 8. And then pica, you're worried about 9, 10, 11, 12 area. 9, 10, 11, 12 is more midline. So yeah. Different scans, circle of Willis runs right around there. Yeah, so just more of the same. Yeah, just kind of have to sit with it and make sure you can identify different things. All right. What did we not do? Is that it? Did we do clinical? Did we do this? No, we didn't do this one. This is the last one. All right. All right, dude got punched in his eye, blowout fracture. Right, so look, split the head in half. You would expect to see the maxillary sinus here. Why is there no air here, like here? Because it's bleeding. He's bleeding into his cavernous sinus because some dude punched him outside the bar, right? So the inferior rectus is trapped there, so he can't look upward. I'm sure that's what they were talking about. Nasal problems. So look at the congestion here. If you split it in half, you would expect to have some nasal areas where air is. It's a lot of nasal inflammation and congestion there, you can see. So yeah, it's just good to go through these and just have an understanding of what's going on. Swelling on the right side of the neck. Looks like one of those, well, is it one of those sinuses? Maybe so. Oh, that was a good one. Yeah, look, this is red here. This is a good place where infections can spread, right? Retropharyngeal space. Danger third space, infection spread to the diaphragm. Okay, I seem to remember a question about this. Like, what is the danger area for spread for, so you get sinus drainage? You can go there. It's more about it here. Yeah. Retropharyngeal space inferiorly to the superior mediastinum, right? So you can get some sort of chest infection. Shortness of breath, cough, and difficulty swallowing. What's he got? Now, that looks like a goiter because it's really big. Yeah, I bet you have difficulty swallowing. That's massive, right? All right, change in voice. Why do you have a change in voice? Because there is some sort of problem with the recurrent laryngeal. Which side? The left one. The left one goes around the arch of the aorta. Probably, yeah. Oh, but look, okay, I'm sorry. Here's a good exception. Yeah, hoarseness would be recurrent laryngeal, right? But a monotone voice will be an injury to the cricothyroid, which is from the superior laryngeal nerve. So hoarseness will be from the recurrent laryngeal. Monotone voice is problem with the cricothyroid. So problems phonating. So you can't, your pitch can't really change. So cricothyroid will be superior laryngeal. So hoarseness and monotone are not the same thing, right? So make sure you know that. And it
Can I
goes
ask a question about that real quick?
Yes.
Okay, so when I was doing Gray's questions, it kept asking about the hoarseness versus monotone voice. And it would say that the external laryngeal nerve was in charge of the monotone voice. And I can see on this slide, you have superior laryngeal nerve and then the arrow saying external laryngeal nerve. Is that a branch of the superior?
Yeah, I believe external laryngeal comes off of the superior laryngeal. Yes, I believe so. Yes. Okay, good. Yeah. So it is. Yeah. So you can have a problem superior laryngeal or external laryngeal, and you can still get this monotone voice. Yeah, for sure.
Perfect. Thanks for clarifying.
No problem. All right. Remember, the one we want to, if you look at this, what do you want to know? What stands out posterior cricoretinoid is the only abductor separates, right? And then another one, I like it when it's more simplified. So it's not got a star, kind of tells you what goes where. Kind of wish they just give us these in the beginning so we could just look at them instead of those pictures. Right, so yeah, you can see here superior laryngeal goes to the external laryngeal. So any sort of problem here, you can get this monotone voice, recurrent laryngeal, and so you get hoarseness. Loss of consciousness, young guy, got knocked out, felt fine, had a lucid interval, then he drops out. What happened? High pressure system, thank you, Kishore. I'm not tired. I don't have to study after this or anything, right? Yes, so yes, could lead to uncle herniation, all that jazz. Y'all know this by now. Middle meningeal, yes, good stuff.
A question about that?
Yes.
So you pointed out some pictures of the arteries that we saw before, like of the external carotid, and
yes.
One of them, like we saw like a picture, I think, of the middle meningeal coming off of the maxillary. Would they give like a question like that on the exam, like, oh, like here's a part of the maxillary, like what kind of hematoma could like come about as a result?
Yeah, for sure. Like, remember, once it comes off of the maxillary, it like dives right into that foramen spinosum. So you think it's protected, but it really runs on the inside of the skull. Yeah, but they could ask that. They could ask the terminal branch of the, what would be the problem? So there's a bunch of different questions they could ask about that. But whenever I think of epidural hematoma, I think I think middle meningeal, right? So it's a high pressure system. It's arterial. That's why it's able to push the brain aside. That's why you get herniation.
Okay.
Yep. All right. The tentorium will separate the cerebrum and the cerebellum. So supracerebral and infra is cerebellar. All right. This is a little bit more detail into what happens where. Just kind of, when you think about it, if you put pressure here, where's everything going to go? Well, the only hole is down here, the foramen magnum. So everything's kind of got to go that way. But yeah, you can work those out. Subdural, remember, older patient, atrophy of the brain, bridging veins. That's what you're worried about. Remember, it crosses the suture line, which is a very important thing, has this lens shape. Epidural here, yeah, you can see that. So subdural is going to cross the suture lines. These will not cross. Remember, epidural is between the periosteum and the dura, and subdural is beneath the dura. So, and then it's going to be with the arachnoid, between the dura and the arachnoid, right? Subarachnoid hemorrhage, you think of that thunderclap headache. It happens very immediately. Patient presents with worst headache of their life, right? You could see it. It's in the middle. It looks like right here, the branch, probably that anterior communicating artery. All right. Yeah, brain doesn't have pain receptors, so that's why you only feel it in the meninges. The Lefort, yes, I would know those. Aren't there like 3 different ones? The Leforts, the different types. Yeah, I would be able to differentiate those. Just know which is which. Yeah, for sure. I think that's it. And we get
There's
into
one
site.
more.
Which
Sorry.
one?
It's the 3rd one of this like series, and that's where they talk about the Lefort fractures.
Okay. Clinical head and neck. There it is. Thank you. All right. Yeah. So it's just some, right. So a lot of times if you get some sort of middle ear infection or outer ear infection, it could drain into the mastoid, those air cells that are behind, you get swelling back there. I guess it's more middle ear than that would make sense. Yeah, gets back there. Remember the facial nerve, that chorda tympani is going to travel through that middle ear, that branch. And then we talked about this already. If there's different lesions at different areas, you can see where they, what would be the deficit, right? Or they could give you the deficit and say, where's the lesion? So this is a good slide. You've got a star. All right, and this is more of the same stuff. You could see our chorda tympani. Oh yeah, wait, so, oh man, what was the question? Something about like, if you have a lesion to the tensor tympani and like you can't control sound. Does anybody remember coming across something like that?
Yeah,
hyperacusis. Yeah, it's like hyperacusis.
There's 2 of them that you could cause hyperacusis.
Okay, yeah, so the 2 muscles you mean?
It's one
Yes.
muscle, the medius.
Okay, so yeah, so if that, and what innervates that? What is it?
7, I believe.
7, okay. Yeah, so if you have a lesion there, you can get this hyperacusis.
Wait, the stapedius, I think that one is done by 7. Nerve to stapedius, I think is that one. And then muscles to stapedius muscle or something. That one is 7. And then there's a different one, the tensor tympani. That one's a muscle by itself, and that I think is a different one.
Okay,
so just someone put in the chat.
Tensor is 7. One of them is V3. So I guess, okay, so
So I have a good way, I think. So tensor, it starts with a T and it's gonna be innervated by the trigeminal, so T. That's how.
Okay. Cool. Okay. Yeah. So yeah, 5. So V3. Thank you. So the branch V3. So if you have a problem with V3, you get this hyperacusis. So what that muscle does is it helps to dampen the sound. It kind of puts tension on it. So hyperacusis will allow it'll just sound too loud. Right. More beautiful diagrams to go through. Gunshot in the upper neck. That's what we like to hear. Slurred speech, tongue is heavy. What side? Right side. So we got shot on the right side. So yeah, lick your lesion. That's the left side, but who cares? All right. To the affected side, y'all know that now. There's a good exception in red. Palatal-glossus is 10. Difficulties ringing in his ears. Vestibular schwannoma, right? Depending on how large these are, these can affect 7 and 8 typically. So because 7 and 8 always travel together, remember Since it's a schwannoma, it'll be unilateral. You'll get unilateral hearing loss on that side. Cut the brain in half. What looks different? This big bad boy right here, right? Look how big that is. That will do some damage. All right. Jugular foramen syndrome. Okay, so if we're affecting jugular foramen, what goes through that? 9, 10, and 11. So if you affect the jugular foramen, you can get an injury to this area, to those muscles, right? All right, and then it goes into the symptoms of that. So different tumors. Oh, that doesn't seem too important. But yeah, so I guess these are the tumors that can cause this jugular foramen syndrome. Cough, nasal congestion and fever. He's got a temp. Well, so we're talking about the cough reflex here, and it kind of breaks it down. Vagus, cough center, right? And you can see that here. So more of the same. Gag reflex, sensories 9, motors 10. See that here. All right, more of the same stuff. What's going on here? Loss of consciousness, headache and tenderness of the nasal bone, facial swelling. Oh, this is the Lefort. All right. So yeah, I would know the differences here. Lefort 1, just the palate. This the palate. 2 is nose and palate. 3, so it's a gradient. 1, 3 being worse. 1 to 3, 3 being worse. So yeah, I would know those for sure. Easy points. All right, cool. So we're good. If y'all have questions, I don't mind talking about the psych stuff. I just feel like they do such a good job. They do such a good job teaching that. I do remember some of the questions in Sakai dealing with the condition, stimulus, and all that stuff were actually a little bit more difficult than the exam questions. I thought the exam was very fair in regards to psych. So make sure you're prepping for BSCE while you do psych. That was intentional to put those together. You don't want to wait to the last minute to do that. I did have a request, PPRF and MLF. So if it's an MLF problem, so say you telling the patient to look to the right, if you look to the right, whatever eye is adducting, like looking medially, that's where the MLF problem would be. So if you tell the patient to look to the right and the left eye can't adduct, it would be a left MLF problem. PPRF is if you tell the patient to look right and both eyes can't look right. So that would mean it would be a right MLF problem because they can't look right. That's the trick. So MLF, whatever eye cannot look inward, that's the side of the problem. PPRF, whichever way both eyes cannot look, that's the side of the problem. Tongue is liquid lesion, uvula is opposite side. Those are all the little tricks to get it done. All right, guys, if y'all have any questions, I'll stay back and answer.
I had one quick question. We had that the schwannoma.
Yeah.
You had you showed, and then it said the other tumor was a cerebral pontine angular tumor or something like that. Sorry, I can't remember. Are there different, what cranial nerves are involved with that? How do you differentiate between the?
I think it depends. I believe they're right around the same area, but because yeah, the cerebral pontine angle, yeah, it's right around that same area. That one may be a little bit higher up, so it could actually affect 3 and 4. But all the questions I remember talk directly about the schwannoma.
Okay.
So yeah, and then it depends, of course, on how big it is. You know.
Yeah.
To how bad it is. Yeah.